Rheumatoid arthritis with swollen legs. Letter of referral. Dear Dr. Mrs. Edna Smith, aged 60 years. Thank you for seeing this woman with a long-standing history of rheumatoid arthritis, for which she has had various treatments. Over the last 2 or 3 months she has noticed progressively increasing swelling of her ankles. On dipstick urinalysis she has proteinuria 3+, on 2 occasions. I have checked her biochemistry, her creatinine is elevated, 170 μmol/L, and her albumin is low, 17 g/dL. Both were normal 2 years ago. I would be grateful for your advice as to the cause of this and regarding her management. Yours sincerely. Introduction. This woman almost certainly has nephrotic syndrome, which could be confirmed by measuring her 24-hour urinary protein excretion or estimating the protein/creatinine or albumin/creatinine ratio in a spot sample. Many different pathological processes in the glomerulus can cause this clinical syndrome, and in adults a renal biopsy will almost certainly be indicated to establish which of these is present in order to guide prognosis and to determine whether specific treatment, e.g. corticosteroids for minimal change nephrotic syndrome, is possible. The history provides clues as to the underlying glomerular process and is crucial in determining what therapeutic interventions and investigations will be indicated before the biopsy. An immediate issue in this case is that the patient clearly has impaired renal function. Is this stable or is it deteriorating? It may be that previous monitoring indicates that the problem is long-standing and stable, but a diagnosis needs to be made rapidly if it is not. If you are not sure about this, then you should either arrange for the serum creatinine to be measured again, to ensure there is no acute deterioration, or see the patient promptly to arrange investigation. NB. Renal failure is best avoided. Remember that a single measurement of creatinine does not tell you whether renal function is stable or deteriorating rapidly. If there is any doubt, recheck the creatinine a few days later. If it is rising, then the tempo of the investigation should be very rapid. History of the presenting problem. Is there anything to suggest chronic renal disease? As mentioned above, a previous serum creatinine measurement would be invaluable, but have there been any previous abnormalities on urinalysis? A history of hypertension might also suggest a long-standing renal problem. Drugs. What medications is the patient taking now and what has she taken in the past? Ask specifically about over-the-counter drugs. Patients do not always count them as medicines. In a patient with rheumatoid arthritis, remember particularly that NSAIDs can cause minimal change nephrotic syndrome, and also acute and chronic interstitial nephritis, although these are not causes of nephrotic syndrome, and that penicillamine and gold can both cause membranous nephropathy. Activity of arthritis, how bad and for how long? As a generalization, the longer and the more active the arthritis, the greater the chance of secondary amyloidosis. Features that might suggest malignancy. Nephrotic syndrome, particularly when caused by membranous glomerulonephritis, can be a complication of malignancy in the older patient. Is there any evidence of this? Has there been any weight loss? Has her bowel habit changed? The presence of worsened constitutional symptoms with joint pains, rashes, or night sweats might indicate the development of a vasculitis as a complication of rheumatoid arthritis. Plan for investigation and management. Is creatinine rising? If it is, then renal biopsy is needed without delay. Serum immunoglobulins, serum and urine electrophoresis, myeloma and other plasma cell dyscrasias are common in this age group. Renal ultrasonography, are there 2 normal-sized unobstructed kidneys? If both kidneys are small, less than 9 cm in length, this indicates chronic disease and biopsy is much less likely to reveal a treatable diagnosis. CXR, any suggestion of malignancy? Does the patient have a low threshold for investigation of gastrointestinal symptoms? This might indicate malignancy. Check iron status and fecal occult bloods, pursuing gastrointestinal investigation if there is evidence of iron deficiency and/or gastrointestinal blood loss. Renal biopsy will certainly be required to establish a diagnosis in this case. NB. Although a renal biopsy will almost certainly be required in a patient with nephrotic syndrome, a proper history and examination are still essential. Further discussion. Diuretics. Massive edema cannot be ignored and needs relief, but note the dangers of overdiuresis, particularly in older patients who can easily feel totally exhausted, develop postural hypotension with risk of falls and suffer acute deterioration in renal function. Aim for 0.5 to 1 kg weight loss per day. Reduce the diuretic dose if this is being exceeded. Tell patients, particularly those given the powerful diuretic metolazone, to check their weight daily at home and omit or stop diuretics if they lose more than 1 kg/day. NB. Furosemide is sequestered by albumin in the renal tubule, so high doses are often required in the nephrotic syndrome. Angiotensin-converting enzyme inhibitors. Any patient with proteinuric renal disease and renal impairment will benefit from an angiotensin-converting enzyme inhibitor to reduce proteinuria and the rate of progression of renal failure. Statins. Lipids are invariably deranged in nephrotic syndrome, but the relationship to cardiovascular risk is not yet clear. There are animal experiments to suggest that lipid-lowering drugs may alter the course of progressive renal failure, but there are no reliable human data concerning this. Statins reduce cholesterol effectively and should be considered if the nephrotic state persists. Anti-inflammatories and analgesics. Remember that NSAIDs cause a predictable fall in glomerular filtration rate. This does not generally cause clinical problems in those with normal renal function, but can do so when kidney function is impaired. If at all possible, this woman should avoid using them and take regular simple analgesics, e.g. paracetamol, for her musculoskeletal pains. Also note that opiates can accumulate in those with renal impairment, and regular doses of co-proximol and similar agents could lead to nausea and drowsiness in this case. Thrombotic tendency. There should be a high index of clinical suspicion when symptoms that could represent a thrombotic complication occur. Of particular note is renal vein thrombosis, which can present with flank/back pain, increasing proteinuria, hematuria, increased microscopic and sometimes macroscopic, rising creatinine. If suspected, the diagnosis can be made by Doppler ultrasonography, requires considerable technical skill, CT, or renal arteriography, looking at the venous phase. If any thrombosis does occur, then anticoagulation should continue for as long as the patient remains nephrotic.